So, good morning, good afternoon, good evening, and welcome to today's webinar. My name is Laura Ceci Galanos. I am the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization, a platform that provides stroke education to health professionals worldwide. Today, with great pleasure, we are hosting this educational activity on the very important topic of enhancing stroke care for women, addressing global gaps and needs, with a panel of exceptional and dedicated women who will be sharing their expertise with you today. As per usual, before introducing today's chair, we were going to have a quick look at some of the housekeeping rules. We welcome any questions you might have throughout the webinar, but we kindly ask you to use the Q&A box for those. So not the chat, but the Q&A box, so that the questions can be addressed at the end. You can use the chat box, of course, to say hi, tell us where you're joining us from, or leave your comments. I'd also like to remind you that the webinar is recorded because we do get this question a lot, and the recording link will be shared with you via email shortly after the webinar, and it will also be uploaded on the World Stroke Academy site. Now, without further ado, it is my pleasure to introduce Associate Professor Aleksandra Pikula. She's a distinguished expert in stroke and cerebrovascular health, serving in the Department of Medicine at the University of Toronto. She holds a J. and Sati Chair in Stroke Prevention and Cerebrovascular Brain Health at the Bill Brain Institute and is the Director of the Stroke Research Program at UHN KBI. Additionally, she co-directs the Women's Neurology Fellowship Program at the University of Toronto, and she also co-chairs the WSO Genesis Gender, Equity, and Diversity in Stroke Care Committee. We are very honored to have her with us today. Dear Aleksandra, the floor is all yours.
Good morning, good afternoon, good evening. Thanks a lot, Laura, for this kind introduction. Thanks everyone for joining our webinar this morning. And thanks to my co-speakers for agreeing to do this together in March when we celebrate also International Women's Day. So it's really my pleasure to first start with introduction of the Genesis Consortium, or rather committee within the World Stroke Organization. Let me just share my slides. I'm having a little, okay, here. You see my slides? Excellent, thank you. So I'll just start with thanking the World Stroke Organization for really allowing us to form this important committee that was established last year in fall, actually, and we had the first meeting in Abu Dhabi. And it's really a committee that will focus on gender equity and diversity in stroke care within the World Stroke Organization. And as you can see, we have members from many different parts of the world. But the mission of the committee is to create an inclusive environment in stroke care, in academic clinical practice and leadership, and really focus on improving access to knowledge and care, encourage clinical trial participation, and develop culturally tailored guidelines and educational tool, while focusing on research, education, engagement, mentorship, advocacy, and promotion. And as we're just taking first steps, and this webinar is one of our aims as well, to really get together and share the knowledge and progress in this space. We're also looking into creating the subcommittees where we'll have non-voting membership, really to allow everyone to participate, and then develop some flagship approach to high impact projects that can affect all geographic areas, while making sure that we have more of such webinars webinars and more presence in a space of international meetings such as World Stroke Congress, International Stroke Conferences, and many others. I would encourage anyone to reach to us if you have any questions or desire to participate, but I'll stop here and really now move forward to introduce the webinar that is going to be a lot of fun. So we have 4 speakers. Everyone will have an opportunity to share their experience in how to enhance stroke care for women to really address the global gaps and needs. We'll have a first speaker, Professor Bindu Menon. She's a neurologist and professor and head of Department of Neurology at Apollo Specialty Hospital in Ellora in India. She's going to be talking about access to care in low-resourced communities. Then I'll be speaking about empowering women for stroke prevention through patient engagement and in the future through digital learning. We have then Dr. Cheryl Kersell, who is the head of a brain health program at the George Institute in Sydney, Australia, and she's going to be talking about future of big data and AI use for stroke care in women. And then we have Dr. Valeria Caso from University of Perugia, Italy, and she's going to be talking about stroke care in global emergencies, specifically to war, pandemic, and other crises. And I'll kindly now invite Dr. Bindu Menon to join the floor and share with us her slides and her talk. Thank you.
Thank you so much, Aleksandra. So I'm going to talk about, let me just put this on the screen show. Yeah. So I'm not going to talk about enhancing stroke care and access to care in low resource communities. And this is something which as part of my foundation and stroke support group I do. So in the couple of next slides, I'm just going to share how what we intertwine with the government policies and how we make our presence as a stroke support organization. And so as we know that stroke is the second leading cause, and particularly to women, if we find that in rural women face greater challenges in accessing the timely stroke care due to the healthcare disparities. Now, this could be because of the lack of awareness which they have, the infrastructure, and more importantly, there are certain culturally relevant interventions which are crucial for improving outcomes. And there are some set rules in the rural communities with which the women are not able to come out and get themselves checked up for any medical, whether it be emergency or for a routine aid. So there is a global disparity. We in India are predominantly a rural population and 70% reside in the rural areas, but most stroke-ready centers are in the urban areas. And that's a bottleneck that we have to make sure that it is equally divided. If not, there is a bend towards a rural area as well. The women in India have a lower health-seeking behavior. We find it more and more often when we do our rural community programs. Only when we reach out to them, we see that they are in huge numbers seeking health aids. But otherwise, particularly as a community, they are not enough motivated to seek medical aid in emergency, as also in the preventive factors itself. This could be because of the socioeconomic factors and also the financial dependence which the women have in India and the gender biases which impact the stroke care access to these patients. Now, putting across what we have been seeing across the last 1 decade and above, the challenges that we face and how we have been able to move forward, and if we could take this and replicate to other countries. So one is a geographical isolation. So there is a huge urban-rural divide, and then that's what we wanted to bridge this divide and see that how we could reach to the rural community, and that's where we found the Neurology on Wheels program, and I would touch on these in a couple of slides. The poor health awareness, so how we could do a new knowledge update to them. So we run our campaign of awareness programs, and we also trying to cater to the community which speaks a dialect of Telugu, so that a fast, let us say BEFAST is not, we cannot communicate with them properly. So we came out with our own stroke mnemonic in that local language. The Ministry of Health and Family Welfare has said that there is a false reassurance of low risk. The women feel that they cannot be affected by stroke or cardiovascular diseases. So that is a false reassurance, and that needs to change. So we brought up the mobile technology with tele-awareness mobile service. We know that telephones are in huge use in country. So we could make use of that and get the information out to the public there. The post-stroke care is something which is very low, and the spectrum of care gets sort of disrupted after the patient goes out of the hospital. So how we can go about it? So we saw that we can make out a stroke help app that is easy to download, that is free to download, and the patients can even use at the rural sector. And then the reach and style. India is a very diverse population, and this population has got several languages, the culture, the religious sentiments, and everything we need to keep in mind. And with that, we came out with a stroke prevention campaign. So as I said, we have a bottleneck where there is an urban population which is extremely very well equipped and with a state-of-art facility for an acute stroke-ready hospital, where the rural population is not having even one neurologist. Having said that, if you would see the slide below, that the number of neurologists per 1,100 population is only 1. So then the number of population which caters even in the urban areas is so very less. So it goes to say that the rural population could never have a chance of getting to a neurologist unless they travel to the neurologist in the urban area. And the ambulance services, we have seen in and out that is the service that helps the patient from the rural sector to reach the urban areas. And this is the best of the care that the Indian government has placed in for the rural community as well as for the urban, of course. The 108 ambulance service, which is established in 22 out of the 28 states and 2 out of the 8 union territories. But then, however, the focus of the ambulance is predominantly on the maternal and the trauma care. And we find that the paramedical staff are not equally and are not at all sometimes trained in stroke care. So the person has a stroke symptom, the 108 is not trained to know which hospital the person should be taken care of. And that's where is our second focus going to be. So what can we do to see that we bridge this gap from the urban to the rural? And that's where we said that the number of people who I should say who travel in the rural and urban India, according to the Ministry of Statistics and Policy Implementation, you would see that it is a huge number that they travel for the health and medical council in the rural areas. So we need to bridge this, and this is where we have made a neurology on wheels. This is a simple bus that has been tuned into a clinic where the patients can wait and then the patients can see the doctor. And we have the bus completely surrounded with all our apps and the logos and our QR codes where they can easily reach and they can listen to the all the awareness programs, whether it be stroke prevention, hypertension, diabetes, and so on and so forth. We have been able to cover this 54 villages in this, and we have seen a sea change in the patients because we have seen that once the prevention part is taken care, the PHC, that the primary health center, is also integrated into the program so that the patients are taken over by the primary health center. So what we do in this program is we follow the motto, we reach, we teach, and we treat. We reach from the rural to the urban areas. With this, we bridge the gap of distance. We teach because then the whole community comes in to see what's happening. So we take this advantage and create the awareness about the factors of stroke, the symptoms of stroke, the golden window period of stroke treatment, and where to reach and how to gain access to that particular hospital. And we bridge the gap of ignorance in this way. In the last is we treat after the patients are screened outside for hypertension, diabetes, body mass index, and rest of the diseases. Then they are given the treatment, and they are also sort of motivated to go into the primary health center, or else they're taken into the stroke support organization. So we bridge the gap of distance, the gap of ignorance, and the gap of treatment. The next is poor health awareness. How can we do about it? So the awareness program, as we say that India is a diverse country and we have to style our awareness program according to the population, and we need to segment our audience. So we focused on 3 parts, that is the school and colleges, where we have structured interventions. We present a questionnaire to them. We take the fund of information from them. We tailor ourselves for the healthier lifestyle, because that's where we should be focusing on for a better future. We give them the FAST and the Be Fast mnemonic. We have interactive programs, and then we distribute pamphlets and ask them to take it back home. In the social organizations where we have more dedicated population, which are more or less with the same principles, like the Red Cross, the Lions, the bank employees, we give them again facts and figures. We come out with that how many pages, it's 1 in 40 seconds, 1 in 4 minutes. We talk with them with facts and figures because they are more mature and they can understand. And detailed risk factors, prevention, and fast and time is brain. And the last is the general public. Now, this is a diverse population. So this population does not understand English very well. For these population, we move from the FAST and the Be Fast mnemonic. We have tailored our mnemonic with the Saregama, that is a musical note in Hindi, where each musical note is pertaining to one symptom of the stroke. With that, this is one of the most famous singers in India. We see to it that it has a greater reach. So we take the help of the famous singer, so that people would be more motivated to listen to that Saregama, because it's a musical note, it is a singer, and then it pertains to the stroke symptoms. The next is a false reassurance of the low risk. What we could do, we use the mobile technology. We can see that the number of people, the number of phone numbers in the population and the connections per 100 citizens is huge in India. And that can be sort of, we need to channelize that. And we use the tele-awareness programs to reach out to the electronic means. We have seen that everybody in the villages have the phones, and this is a number that they can dial in, and they can listen to 3 to 5 minute dialogue on stroke, and as also an epilepsy and migraine on that number, and that is present in 3 languages, that is English, Hindi, and the Telugu. So this number has got a huge reach, and we get number of calls on this. We can know how many numbers of calls have been made on this, and this has been very effective, because it's a very short and crisp message that is followed on. Then we have the post-stroke care. As I said, the spectrum of care gets stopped. During the COVID-19 time, we found that the patients are not even able to come to the hospital. So this is the best way we can reach them out. And we had the post-stroke help app. The stroke help app is easily downloaded on the Google Play Store. And this is convenient. It is more repetitive. It has got a flexibility and control, and it's very simple to use. And it has got around 47 lessons here. And it is in limb exercises, hand and dexterity exercises, coordination, and vision. And it covers the whole spectrum, and the patients can keep looking at the videos, which is very easy. And it is done on a particular subject by a physiotherapist. And this we have seen, again, we have a study done on it. We saw that the patients who use the stroke help app, even in the rural population, the women, because they have the phone in their hand, it is easy for them to do a repetitive exercises on that. The last was the reach and style and the social media and the stroke prevention campaign. As we know that post-COVID, the social media has become very popular, and we wanted to use it and channelize and tap that potential of the social media campaign. And we used the stroke prevention campaign for a particular year, especially targeting to women. And each month we targeted for one particular risk factor, going from quit smoking and alcohol, manage stress, depression, to the last as exercising regularly and managing your weight. And we saw to it that every particular month when we had this convenient sampling of women who came into the hospital, or when we went for any of our awareness programs to check the blood pressure, if it was sugar, to check the sugars. And there was a huge number that we could detect that in the convenient sampling. And that was not only an awareness program, it was also an eye-opener for them. The last is the EduVan, that, as we said, to tailor this in educating women about the neurological diseases. Now, the need is, we feel that educating a woman would in turn, because a woman not only is a person who can prevent the disease, but also, as we found in our own studies, that she is essentially the caregiver in an Indian close-knit family. So the outline of the project that we do is a risk factor identification. risk factor prevention. We teach them how to check the blood sugar. We teach them how to check the blood sugars and the BP. We also teach them how to download the body mass index and to check the body weight and the height. And we empower them with all of these knowledge. How can they be prepared during a stroke attack? And then these are targeted to the self-help women groups and organizations with women employees. Apart from that, the Indian government also has a population-based screening for finding suspected cases of hypertension in women. And we have these paramedical staff. These are the ASHA, the Anganwadi, and the community health workers. They're a huge number in the primary health centers. And we try to sort of integrate with them and form our EduVan project so that when these ASHA workers and the Anganwadi workers have their once per month meeting, we go our awareness programs as also into the public. It starts from not only the blood pressure, the blood sugar, the body mass index. We also see to it that a 5-gram salt is how much. That's how the lady is showing there, that this is essentially what a person is supposed to eat. And that's the basis as we can prevent a hypertension in that patient. So in these, we have found that the 4 pillars of our stroke support organization is strength, awareness, and early recognition, improving the access to early diagnosis and treatment, addressing the financial barriers and the policy support for with government schemes, the CSR and the local NGOs, and strengthening the post-stroke rehabilitation and support by EduVan and community-based rehabilitation. And probably in the future, we are trying to get some AI tools so that we can connect to them in a better manner. Thank you for giving me this opportunity, and also my wonderful team who are there with me for all of my programs and projects. Thank you so much.
Thank you, Dr. Menon. This was fantastic. Thanks for sharing your experience. And I guess I'll take over and share my slides now, and we'll leave some questions at the end for you and the team as well. Let me just share my slides now. So I will continue the webinar and talk a little bit about empowering women for stroke prevention. These are my disclosures. And really, to put this into perspective, in Canada and in many other parts of the world, the stroke care is becoming very complex. And what applies for acute stroke management certainly does not apply for chronic care models. And definitely there is a difference in primary and primordial, primary and secondary prevention of stroke. And if you put social determinants of health and gender disparities, obviously the care is becoming much and much more complex. However, yes?
Sorry, we cannot see your slides currently.
I'm sorry.
No problem.
Looks like I shared them. Do you see them now?
Yes, now we do.
Okay, thank you. So I'm here. You see the main slide.
Yeah.
So I'll just continue, and you know, there is more and more need in terms of the people engagement or people with lived experience engagement, such as family, patient, family, and caregivers into the models of care. We're lucky here at University Health Networks, where I work in Toronto, where we have quite robust program that really guides us on how to do that. And more importantly, more and more granting agencies are routinely looking for this piece of grant to be involved in our research processes. So with that in mind, learning objectives of my talk is to quickly review the evidence, then touch a bit upon gaps and needs around lack of awareness and knowledge, and also what really our patients need in our distinct communities, as illustrated by Dr. Menon in her experience. So we know that global incidence of stroke is up, and it's going to continue to rise. So prevention is the key. But important evidence is that 50% of stroke population are women. Their lifetime risk of stroke is higher than in men. And during midlife, women's risk doubles compared to men of the same age with the same risks in the background. And there are important female-specific risks that we should take in consideration when assessing our patient. Female-specific risks are adverse pregnancy outcomes, early menopause less than 40, and menopausal transition and vasomotor symptoms. And we know that all of these female-specific risk factors do lead to increased risk during midlife. And more importantly, conditions such as hypertension, diabetes, obesity, migraine, atrial fibrillation have much stronger effect on stroke risk and risk for vascular cognitive impairment in women during the menopausal transition. So there is a lack of female-specific data collection, and I'm sure Dr. Carcel will touch upon this and the importance of it when we're doing research and doing quality improvement studies or admin data assessments. But there are also lack of female-specific risk scores for the same reason. So even though we have guidelines, medical community awareness really does not necessarily recognize or screens for female-specific risks. And there are many reasons for that. But again, this slide, it's really to call on, existing guidelines for primary prevention and secondary prevention of stroke, where we have a really nice lineup of recommendations for stroke in women. How to improve the education for the physicians and healthcare providers, to really be embraced to take care of stroke in women and specifically focus on stroke prevention in women. There are many ways, and we have the whole program around this here in Toronto. But optimizing clinical training, research training, and knowledge translation in the community with the primary care providers and local institutions, it's very important while we're building networks such as national and global networks that will embrace what's missing currently. It's important also to take into consideration that public and patients' community and knowledge is very important. And currently, when you look from any countries, when there are reports in terms of the papers or perhaps surveys from national institutes, there is really low health literacy among women and general population about stroke risk or stroke signs. And specific to Canada, in 2018, Heart and Stroke Foundation of Canada actually had a survey, global survey, assessing for the knowledge around stroke risks. And 70% of women did not know about any stroke risk factors. So it's really concerning. So even if we have, like a provider-faced tools, we still need to have a patient-faced tools for decreasing the risk of stroke in women. What about the post-stroke educational needs? I mean, there are many, and there are very few studies. And there is a paper that actually pulled available studies in 2011, looking at, what are the educational needs of patients with stroke and their caregivers for many unmet from stroke prevention to essentially post-rehab needs. Really, the conclusion was that even though there are many unmet needs, they are not specified to women. And that's what brings us to patient engagement in research framework that we have at University Health Networks. And my team and I've been doing research around assessing the needs, knowledge, current habits, motivators, and barriers, really to understand what else we can offer when we're trying to implement the new models of care. But again, you can only focus on your specific population. So really the questions for our research in the last 5 years is, what do my patient need here in this space? And these are difficult studies to do because we don't use the admin data or perhaps observational data or population, but real people data where we're examining patient-reported outcomes, their needs, care preferences through the quantitative and qualitative methodology. where essentially you collect data about their risks, their outcomes, but then you deep dive through focus groups to understand what they would really like to see longitudinally in terms of their stroke prevention. And the reason we're doing this, it's really to develop the content, to understand the knowledge, practice barriers, and facilitators to be able to feed the content for digital learning that is embraced nowadays in many other professions and medical fields. So what we learned from many studies, and I'm just selecting as an example here a few, when assessing education and care delivery and preferences, women prefer on-demand and in-person support. They prefer focus on self-management and group exercises and group visits. They really focus on physical, emotional, and psychosocial health, return to work, and self-identity post-stroke. And they would like to see this as a longitudinal care, not only one-point care. When assessing knowledge, what we have done, we assess knowledge across the Essential Life 8 and Brain Care score. And what we have observed is that what people don't necessarily do. So women have more knowledge, but they're not applying that knowledge. For example, if they know what the risky nutritional pattern is, that doesn't mean that they'll be performing that in their real life. So essentially, women are very driven, when they're working on their self-management for stroke prevention through the Essential Life 8 to rely on their emotions, and that sometimes really affects the eating habits. And the same speaks for physical activity, for sleep, and many other risk factors that are along the lifestyle modification. So knowing that, now we're developing intervention that has been funded by Ministry of Health to essentially really optimize the learning around how to do certain things. If there are needs, if there are care preferences, if there is knowledge, the question is how they can integrate that in their lives. And things get more complicated once you start doing the qualitative research, because then you learn about, facilitators and barriers that we can, as medical providers, cannot necessarily fix because the needs are endless. But again, when you embrace those essential needs around education, you can come up with this amazing tool that our patients co-designed with us, and we just finalized the toolkit and design of 5 models that will be going into digital learning for women who would like to essentially embrace stroke prevention through self-care. This specific tool was developed by young mid-age women who had a stroke and high-risk profile, had been parents for children of different age groups, diverse cultures, ethnics, and social determinants of health. And they met with our coordination and discuss what is missing in the healthcare that they are not getting necessarily after they leave the hospital and finish their rehab. And really everything kind of collided around parenting and becoming a parent after stroke and returning to work, taking care of themselves, and really taking care of their mental health. While the most robust module was about women's reproductive health, their risks post-stroke in terms of the pregnancy and how to handle menopause. And this is probably the first tool that hopefully will be translating in a couple of languages to be accessible here in Canada, at least, that was co-designed by Women for Stroke Prevention. And then the question is, how do you deliver this content? It could be delivered in many different ways, but in the world of digital learning and mobile apps, obviously that would be the first step for us to develop. However, as I mentioned at the beginning, we're facing the world of digital health and digital learning, as well as AI and big data. But we have to understand that, we need tools for clinicians and we need tools for patients. So, and they're very different needs. And when we're developing those risk profiles, they don't necessarily benefit our patients. So we have to be really very vigilant around patient engagement when we're doing, development of digital technology for stroke prevention. I'll just move quickly through a couple of examples where web-based digital tools are being in progress in terms of development for women. But again, as I mentioned, the development of the content, it's really important to be embraced for local population and needs, as Dr. Menon mentioned her experience. And then maybe that could be coordinated at the large networks to expand for others. And there are a couple of examples here in Canada as well as in Australia that I'm aware of, but there are several promising tools that can be optimized for population use and patient engagement to optimize the courses in digital technology for stroke prevention in women. Really, the takeaway message when we talk about stroke prevention in women, there is a massive knowledge gap among healthcare providers and patients about female-specific risk factors, and guidelines on screening and management is not yet well implemented. There is a need for female-specific risk tools. There is also a need for robust education around sex-gender disparities in stroke during residency and fellowship training. And there is a need for patient and caregivers engagement in education content development when we're teaching about stroke prevention. Qualitative data is still to enter the AI space. It's not as quantitative data where it's easy to perhaps machine learn. And then digital learning, while it's emerging, I think we still have to focus on peer support and real life experience when we're developing new models of care. So I'll stop here. And again, thanks to World Stroke Academy for organizing this. And I, again, wish you a happy International Women's Day. And I'll pass it to Dr. Caso.
Apologies, my internet's a bit slow, but can you see my slides now?
Yes, we can.
Thanks, Laura. Thank you to the World Stroke Academy and Aleksandra and Valeria for having me here today and for the opportunity to speak. And also, I'd like to greet everybody in advance. Happy International Women's Day. Right. Artificial intelligence and machine learning can enable precision medicine and implementation science in cardiovascular research and clinical care. But before we sort of get into this, I was hoping to start with a few definitions, and I'm sorry if many of you know this already, but might be important in sort of establishing what we mean by AI, which is the study of intelligent agents which can perceive the environment and act as humans do, typically for very narrowly defined tasks, whereas machine learning involves the scientific study of statistical and mathematical models and algorithms which can progressively learn from data to achieve sort of a desired performance on a specific tasks. And machine learning can be used for tasks that need automation, standardization, and is very well suited where humans find it difficult to manually develop a set of rules for desired tasks. So AI can facilitate precision medicine as opposed to the preponderant one-size-fits-all approach. Precision medicine attempts to find personalized preventative therapeutic strategies by taking into account differences in sex, intersectionality, environment, lifestyle throughout the lifespan. And on this slide, you'll see artificial intelligence used in heart disease. And we can see, I don't know if you can see my mouse, but I'm sort of pointing to the left-hand side of the image where we have all these different clinical applications: imaging, ECGs, continuous bedside monitoring, so wearable technologies, electronic health records. And these are some of the things that machine learning can do, to improve patient safety and really to provide precision medicine, but they're not without gaps and challenges. But this is this picture now is talking about really AI use in maybe research and clinical decision making, and that's in one space. But also there is this space of where patients have started using AI in healthcare, and this paper was published at the Age in Australia just last month, and you'll see the person holding her screen up, talking to ChatGPT, and that person's not alone. I think we have so many patients coming into clinic these days who have probably uploaded their medical records and imaging into ChatGPT, asking, what's the possible diagnosis for this condition, and they come to the clinic armed with sort of these differential diagnoses, and that's great because people are taking ownership of what they do, but also it would be detrimental if you kind of use AI that has no training in this area. And so now with the wide use of AI in the clinical and non-clinical space, and the knowledge that this field is growing really rapidly, we need to ensure that everyone is considered so that data generated by AI will be unbiased and no one is left behind. AI, I mentioned a bit earlier, can involve algorithms or instructions run by software. And these algorithms can act like an extra set of eyes, like looking through laboratory tests or imaging, for example, looking at CT scans, checking particular shapes and colors that could indicate a certain type of injury or stroke. Problems with bias can emerge at different stages of AI development or deployment. And one major factor where we can see bias forming is when algorithms are used on non-representative data sets, or they're trained on these non-representative patient data sets where race, ethnicity, sex, and socioeconomic status are disregarded. And so they're trained on this purely one model. And also, many clinicians are unaware that these AI medical devices have potentially skewed results. And so some of the one example I found that was put out by the Gendered Innovations Group is the pulse oximeter. And we know that this device has been around for many, many years, over 50 years, and it can quickly and non-invasively report oxygen level in a patient's blood. And so these devices are very useful in hospital, but also during COVID, they were used everywhere and used to determine whether a patient needed to receive emergency supplemental oxygen to prevent organ damage and failure. So these pulse oximeters work by shining a light through a patient's skin to register light absorption by oxygenated and deoxygenated red blood cells. However, the melanin, which is the primary pigment that gives our skin color, also absorbs light and potentially can scramble readings in patients with highly pigmented skin. So many of the studies have shown that in these usual pulse oximeters sold by industry, they're 3 times more likely to incorrectly report blood gas levels in Black patients compared to white patients. And there's also an additional sex bias. I'm not entirely sure what the mechanism here is, but they tend, these oximeters tend to misstate levels in women more often than men. So you can imagine that in dark-skinned individuals, especially females, during COVID time, they were probably not given as much emergency supplemental oxygen if it was just based on these oximeters. So, but what are sort of the opportunities here? We've talked about some of the detrimental effects if AI is not trained on a representative sample. AI has capacity to reduce undesirable bias, and we see that on the left-hand side as stigma, discrimination, again, using unrepresentative samples and adverse reactions and effective treatment. But it also has the opportunity to enhance, understanding of sex and gender differences, effective treatments for different sexes and genders, and the well-being of patients. And this sort of all feeds into the health and well-being of our patients and improving access to healthcare. Discussed a bit about the pulse oximeter, and what about examples in stroke? This is a publication. This is a paper looking at publications on the applications of AI in stroke in the past 20 years, and it grew from 16 to over 4,000, with the US having the most publications, China, and then Italy, and stroke. So there's lots of use in AI, and one of the examples that we may know is that using AI systems such as Rapid AI, which has proved to be sort of an efficient tool in identifying candidates for reperfusion therapy. And this Rapid AI was used in several trials, including Diffuse 3 and Dawn, really to triage patients into reperfusion or not. And this is already in thousands of hospitals around the world on the basis of results of these randomized controlled trials. So I've tried to look for AI use in stroke care to improve women's outcomes, but I haven't found any, and maybe people in the audience can correct me, or people in this panel would know, but this is a really good one. It's called GRACE. It's a GRACE registry, Global Registry of Acute Coronary Events. And as usual, many things happen first in heart disease and follow on from stroke. But this was an effort, so the GRACE registry was an effort to improve individual mortality and adverse outcome forecasts. And it's a scoring system introduced over 2 decades ago, and is a central tool to guide patient stratification in acute coronary events. And so to date, it's improved outcomes following risk stratified patient management. There's been documented clinical trials on it, and individual patient data meta-analyses. However, there's a continuous evolution of the acute coronary syndrome phenotypes, and also this emerged evidence suggesting that there are biological differences in acute coronary syndromes between sexes. And I'm sure we all know that women are generally older, have higher comorbidity burden, different sort of plaque mechanism and type in women compared to men. So these sort of differences need to be considered. And what they've done is with this GRACE 3.0 is that not only have they, so they've redeveloped the tool, and this sort of integrates the prognostic information from the previous scoring versions, but sort of they've trained it externally in very large data sets, but they've also for the first time accounted for sex differences in the risk factor profile, which is great. And this GRACE 3.0 integrating all these new things have really have been shown to have good predictive performance that allows more accurate patient stratification. And in addition to sort of in having these. The authors have also published the web link to this GRACE 3.0 online. So it's really available. And this is my last, second to the last slide. And this is just really rounding things up in terms of where to from here. This is a framework for successful implementation of AI or machine learning in cardiovascular medicine. And I won't read through the whole of it because I know we're running short on time, and Valeria is very ready to go. But you can see here that so we really need to ensure that AI and machine learnings are safe. It needs to incorporate social determinants of health and also protect people who are at risk. Thank you. Thanks very much. I'll stop sharing now.
Thank you, Cheryl. I think I'll invite Valeria now to the podium and share her slides, and then we'll take the questions at the end.
Thank you very much. I will now. Okay, do you see my slides?
Yes.
Yes.
Yes, thank you very much. Now it's my turn to move to a completely different setting. You heard wonderful things about what we can do and about artificial intelligence. And I think now I'm talking about what is the challenges, and especially when you're talking about war, for me, it's the highest regression of what doctor can experience. And so this, you know what we are, when we are we're talking about stroke patients, and stroke patients, they need a very structured care system, because in 1 second, we are working all in the same settings. You pass from being able to disabled, and you need resources because it's a chain of recovery. So you have the acute treatment, you have the rehabilitation, you have the life after stroke. So all these fragile, because it's not only frail, but it's also fragile patient need to recover in the best possible environment. And you can imagine when you are outside this best possible environment, everything's become extremely difficult. And as I said, you require an organized and coordinated model of care, rehabilitation. If there's any kind of complication, you need to have additional care. So sometimes you also need to have palliative care. So in different setting, which is not normality, everything becomes so extremely difficult. So we are living more and more natural disasters, and the last one that we experienced and went through the news was before the American Stroke Association, this big fire in Los Angeles. And you can see how much also there is changes in incidence and prevalence of ischemic stroke due to natural disaster. Again, we know that stroke is 80% preventable. But, and we are telling our patient, and you see the wonderful program from Aleksandra, we are trying really to protect our patient day by day from themselves, from aging and so on. And then you have this terrible event like a natural disaster where the CO2 raise like hell in an uncontrolled way. And you will see that you have the natural disaster have a clear influence on the oxidative stress, inflammation, mental disorder, because I want everybody of us now living at our homes, if you are outside your home, there's fire, there is flu, there's everything, and how you can continue to do your job. And you know that there's also an impact of hypertension, BMI, smoking, alcohol abuse, because due to the stress, and also the access to medical service is hindered. So this is it's not only the practical thing, but also the direct and indirect damages due to the natural disaster. COVID, you remember what we went through, and I live in a country, we were the first European country, and what I saw in this 2020, 2021 was something that I thought never to experience. Because first of all, I was honestly not involved in the treatment of COVID patients, but some of my colleagues decided to go to the COVID ward. And what I heard from them in an indirect way, it was heartbreaking. And we also experienced that the fact that patients did not come to the hospital because they were afraid. So there was no way to protect stroke patients. And we see now the increase of diabetes, the increase of hypertension, the weight increase. We now see an increase of all our stroke patients after this terrible year of the COVID pandemic. And you know how many times we saw, don't stay home, come to the hospital when you have a stroke. And because patient didn't want to come. And this was especially not so much the severe stroke, because the severe stroke they will send you, but all this mild and moderate stroke who did not start secondary prevention because patient and relatives didn't want to go. This is something that we are paying now. But the most disrupting events is clear the war scenario. And we know, again, it's not about saying war is terrible. War is terrible because it's terrible. But as a doctor, as vascular physician, we know that, again, we have an increased blood pressure, we have more lipid, alcohol, tobacco use, and there is a clear post-traumatic stress, and we are still in countries like Serbia, Croatia, Bosnia. We are still seeing because the war was in 1994, that there is still sequela from the wartime. And clearly what we will see in the West Bank, in Gaza, probably there will be, because now we're seeing, like always, the direct damage on people due to the war, but what we will see is what will continue for years after. This is because we wrote a paper together with some colleague. I studied the number of the war, and I was really so shocked, because 1 in 6 people of the world, which means 1 billion, live now in areas which are affected by active conflict. And it's the worst thing is also that the number of, and you know, I'm living in Europe, and I grew up, I'm born in 1966, so not so far, it's far from the war, but not so far. And when we grew up and we were protesting a little bit, I lived also the Cold War, never again war. We repeated ourselves, never again war, never again, we have to fight, we have to do this. And unfortunately, the number have now of wars increased around the world. And here you see the different areas of the world where we have active war. In our paper, we analyze stroke care in some countries. It's clear when you have countries like Yemen or Sudan, where was not so much in place, the disruption of the war is even worse, because when you have countries like I will show you the other example, like Ukraine, who had already something on in place, the stroke treatment was not so disrupted, except clearly in the area of Odessa, Cardiff, and so on. And mostly you can see in Yemen only private sector survived and providing thrombectomy, and there is no CT perfusion, CTAs. There is also what you do. Sometimes you don't think about it. There are military checkpoints. So for example, you have an acute stroke and you have to pass military checkpoints. Or this is especially when you have an internal war, do you trust to go to the hospital where is the other fraction of the war? Even if we as a doctor, we will probably treat everybody, but you never, there's such a situation of mistrust, which is, it's very difficult to overcome. And clearly, when you are on the no-go list for many countries, it's clearly that you cannot leave. I met now recently a colleague from Yemen. We were in Kuwait, and to reach Kuwait, there was no airplane, there was nothing. He came by traveling by car, long trip. So, and to do some medical education, so something that you never really think about it. Sudan, same situation like Yemen, even worse. Again, there was nothing. They lost due to the war stroke services, and it's also one of the worst humanitarian disaster in the recent memory. The example that I know more, because I'm living in Europe, is the example of Ukraine. Ukraine had the possibility, because Ukraine is a big country, you have to consider that the war is in the area of the eastern part. Clearly, there is a bombing also to Kiev, and unfortunately even to Lviv. But the rest of the country was able to continue to work. It doesn't mean that the stress, the continuous stress, because the men, you know, that they cannot leave the country, because in a condition of war, men cannot leave country, because this will be considered as somebody who will not do their military job. So they were able, because there was a long process before in maintaining thrombectomy and thrombolysis, because there was a lot of help also from industry and projects. So they could maintain the treatment for these patients. But now, just to remind where we are, because we are talking about women, and we know that women, and we are 60% of health worker are women. And also this means when there is, and you know, we see this now in all war scenarios, that there's no longer don't bomb the hospital. Unfortunately, there's no country where there was a respect for so-called frank zone where you cannot bomb. And most of us, there will be female doctors, more female doctors. The other point that with war, invasion, there's an increase of rapes. And also this is something that we need to keep in mind. And also that this is a study that was sent to me by Aleksandra about the war-induced stress of arterial hypertension. And this is on Ukrainian refugee women, and clearly there is an increase of hypertension, even if you're not directly involved as a soldier, but being refugees increase your stress. Same here is another important, again, talking about women, the intimate partner violence among veterans after Iraq. And you can see that women in relationship with this veteran have to face higher risk of psychological, physical abuse, we know that many of these veterans have a poor emotional regulation, because you can tell me what you want. You can be as skilled, as educated as you want, but I don't think that it's good for a soul of human being to kill, to be, even if you know it's part of your duty, but still we know the post-traumatic stress in those who were at war is really something that will affect them for the rest of their life. We created here, this is something again from our paper, some of mitigation and action that should be done. For example, we know that thrombolysis is an essential drug. So we have to involve WHO in supporting our colleagues in war. We have to, there are scientific society like ESO, WSO, American Stroke Association, everybody who is willing to support in teaching, because there will be a psychological impact for our healthcare worker. They have to face, and I can tell you, in my small experience of COVID, I could not treat my stroke patient as I wanted, and this brought me to a severe breakdown, and I needed months to get out of this, because I felt like everything was destroyed and I could not do what was my duty. And also we have to think about all the financial barriers. So we have to involve also industry there. I'm not here to tell you about the industrial how can I say, action, but big sponsors supported, for example, the setup of stroke units in Ukraine. Just this was published on Christmas from WHO. Health is a bridge to peace, and if you can, sometimes even WHO was able to interrupt the so-called days of tranquility, where you could do some vaccination or whatsoever. And I think this is something that we need to always to say, stop. We have to do something for the population. I'm not here to speak about the morality of war, because it's clear, you understood already my feeling about war, but I'm talking here about health. And when there's a moment where we have to support the patients, and clearly there should be a possibility to do healthcare action. So this is the concept of preparedness, to say the first days you focus on the life-threatening of treatment, then you move to continuing response, to expand the management to subacute and chronic NCDs, and then you help the access to treatment, and with all you create SOP for referral and so on. Just to conclude, 1 of 5 people live with one or more NCDs. And now 1 billion people live in war zones, and 71 million people are internally displaced in their own country, and there are 36 millions of refugees. So this is an example, because maybe you can say, why you're talking about war. This is the Ukraine, the ESO task force for Ukraine. We went to Ukraine. We were able to go to Lviv to do education with our colleagues from Ukraine. And I think that this kind of normality, we did not solve the war. We did not solve a lot of things, but we were there to teach, to support, and to say we are here to support our patient. We are not here to judge who is right, who is wrong. We are here only to support the patients. Thank you very much for your attention.
Thank you, Valeria. This was quite moving, so a really important topic, and thanks for sharing this. I know we're over time. There is a passion about this topic, and we like to talk about it in all our spaces. However, Laura, I don't know if we can perhaps open for a few questions. If there are any, we answer some in the background.
Absolutely.
But if people would have any questions, we'll stay a few minutes extra. And I see a lot of thank yous, and really appreciate for all of your nice comments and for joining this morning, this afternoon, or this evening.
Can I ask a question about?
Yes. Yes. Mm-hmm.
Yes,
sure.
Thank you.
Yeah.
Cheryl, about the question about the training of AI. you see, for example, there's this famous model about if you have a car and you have to save people. If you are in Asia, because you value the oldest people because they are appreciated, they are the part of knowledge, you would save elderly people. When you go to Europe, you would, or Western, let's say more Western experience would say, IE would choose to sacrifice elderly people in order to protect young people. So it's about the ethnicity. And again, I think we have how much, and I'm working a lot on IE also for stroke detection and so on. But the concept of ethnicity, especially when we're talking about gender, I think this is something that we have to be very careful and very attentive that we educate, we train the model in the right way.
Thanks, Valeria. And I think, and thank you for your talk. I agree with Aleksandra. That was really moving and something that we don't hear often. With regards to AI, I think you're right. There's been quite a lot of sort of information about training AI properly and needs to incorporate, not just gender, race, or ethnicity, but maybe also other social determinants of health. And really that comes back to where these AIs are trained, what representative samples that's being used. And often where the AI is developed is more in high income countries with really maybe homogeneous samples. So yeah, I think you're right. Then there needs to be some sort of regulation on how this can be done. And I think that framework is quite a good one to start. It's from AHA, and in the slides I've put together some other resources there. So that might be sort of a starting point for people.
If I may add, I think, it's also very important to consider the geographic area when you're implementing AI and what data goes in. That's the data that, machine learns to input the next step for the population you're going to use that AI. My concern, and me being more into qualitative research lately, is that actually the real sort of soft data is not captured, and that becomes very robotic use of management of chronic conditions. For acute care, I see fantastic utilization of AI data, but I'm not yet certain that we're ready for the management of chronic illness above and beyond pharmacotherapeutics for the same reason. When we were developing, for example, this toolkit, educational toolkit for parenting after stroke, which doesn't exist really, you encounter stories that it's not only the stroke, it's a woman that takes care of a kid that has disabilities. So it's not the same as a woman that does not have children. So that's the whole sort of a range of needs that are not captured by any population or admin data sets. And the question is, how do you train the model to those soft needs, which are actually quite dramatic, not even soft. We just call them soft because we cannot measure them with objective numbers. But I guess I'll bounce this, Valeria, if you don't mind, to Bindu, because I think she deals with a variety of population in a rural area. And how do you see that being used in the space where you practice? You're muted.
We are in a changing times now, and the rural population, having said that, their interest to access the medical aid is less, but their interest in using gadgets is going very high. So I suppose that's the best way to leverage that technology to their interest, cater to their interest, and probably use it to the best of use. And I have seen that they are doing that. As I tell you that they are how much they would be able to sustain that use of the app or continue to use that. That is a different question. But they're open to a situation where they want to be a part of something which is more technology driven.
That's interesting, you know, because we are running now the shared medical appointments, and we're getting quite opposite, actually. Women want more connection rather than tools. And I guess that's exactly where we talk about these geographic areas where there is a saturation of certain things and where is the need for more. So, you know, I mean, it's interesting space we're in.
Yeah.
Excellent. Okay, so I guess we're done. No questions. Laura, if you wanna perhaps take the podium on.
Thank you so much. Great presentations and great questions. Just a reminder from my side that the World Stroke Academy has a dedicated page on women in stroke. There is the QR code for you to scan there. In this page, you'll find e-learning modules, case studies that feature female patients, as well as interviews and all of the webinars that we have done on this topic. So all the resources are available there. And just an invitation to our next webinar, ischemic stroke module of the educational program for stroke centers of the WSO, which will be taking place on March 18th. So we hope to see you all there. And until then, take care and thank you very much to our audience and our panel today.
Thanks,
Thank you.
everyone.
Thank you.
Bye-bye.
Bye.
Bye.